I think it's important to talk about asthma just because of where we live. In our beautiful rural community, we have one of the poorest air qualities in the state of California. So, asthma, the condition in which your airways narrow and swell and produce extra mucus. So that's going to make breathing difficult, trigger coughing, wheezing, and shortness of breath. For some people, asthma could be a minor nuisance, but for others who have it as a major problem that interferes with daily activities, could lead to life-threatening asthma attacks. Although asthma cannot be cured, its symptoms can be controlled. So asthma symptoms vary from person to person. You may have frequent or infrequent asthma attacks, have symptoms only at certain times, such as exercising, or have symptoms all the time. So we need to figure out what type your patient is. So is this condition chronic or acute? And depending on the severity of the condition, how bad does the inflammation get? Triggers of asthma. Allergens. Allergy-induced asthma, such as airborne substances, perfumes, or when you decide to spray Febreze, pollen, mold spores, cockroach, waste, yes, those nasty little buggers, particles of skin, and dried saliva shed by pets, or even pet dander. Exercise-induced asthma may be worse when the air is cold and dry. I'm going to go back to allergy-induced asthma. So when my son was younger, if he was exposed to like certain perfumes or or certain detergents that have, fragrance, it would cause him to wheeze a lot of congestion. He just couldn't breathe well. So we are now a hypoallergenic home. Let's see. Also, an example with drug and food additives. When my son was born, he also had the condition where he could not break down milk protein. So it's not necessarily lactose or milk allergen. It's the milk protein. So it's called MPSI. So milk protein sensitive intolerance. It does exist. So the first year of his life, I said sensitive. No, it's MSPI. Rewind, MSPI, milk, soy, protein intolerant. So he also couldn't tolerate soy products. So the first year of his life, pretty much everything was homemade and all packaging and was read very thoroughly, just because of, first he would get skin conditions as far as eczema and hives, and then he'd also have breathing problems, which led to GERD. And so he had to take something for his GERD at night. He always had to sit up during feeding, so it was a whirlwind. It was a whirlwind. So those are triggers of asthma. It's just a flow chart of the differences between early and late phases of responses of asthma, depending on your patient. So as you can see, it can happen within 5 to 6 hours or 30 to 60 minutes. So your trigger has activated the inflammatory response system. Now we have a bunch of mucus that's being produced. Which is now causing a bunch to hang out here. And what's going to happen to that particular smooth muscle area? Well, now it's going to have muscle spasm. It's extremely swollen from the mucus. And now you have a constricted airway. And this is just one little branch. Just think of all the other branches in your respiratory system. So you have a reduction in airway diameter, and now airway cannot pass through it because of increased resistance due to the mucus production. Now you have that constricted smooth muscle, and the mucus just keeps producing and producing. So what does asthma look like? Most of the responses are going to be, well, they're going to be wheezing. Well, yeah, they're going to be wheezing because of why? They are wheezing because of the constricted airway. Shortness of breath is going to occur, chest tightness, trouble sleeping caused by shortness of breath. Let's see here. Silent chest. Silent chest. Not a very good sign. So you need to determine whether the patient has a severe asthma exacerbation. Let's just say the patient was wheezing 20 minutes ago, and then all of a sudden there is no wheezing, also known as silent chest. Your patient now has a severe airway obstruction or so fatigued from trying to breathe that they are unable to generate enough airflow to wheeze. So, ominous sign of impending respiratory failure. So, your patient is very aware of what's going on. They're having trouble breathing. So far, they have enough oxygen to the brain flow to be aware and alert to what's going on. So how does it make them feel? How does it feel when someone places a pillow over your face? Of course, you're going to feel super anxious. And now the patient with asthma and all that mucus production, he can't even move it. Because what's going to be important? Trying to breathe or trying to, cough up all the secretions? Well, now it's a vicious cycle. He can't breathe because of those secretions. But I would rather want to breathe. So now they're feeling they're in trouble. Now you're monitoring for signs of hypoxemia. So when they're alert, you're going to see them restless, increased anxiety, inappropriate behavior. At first, you're going to see increased, heart rate, respiratory rate. And all of a sudden, you have a drop in systolic BP. And then, what are you going to do next? At that point, your patient's probably in the most highly sought complication of asthma, status asthmaticus. Life-threatening, where the patient poses risk for respiratory failure, that silent chest. Airway is so obstructed or they're so tired that there is now no airflow. So, let's rewind, bring it back. Let's just say your patient's here for a routine visit. We're going to take a detailed history and physical exam. How long have they had asthma? Is it since childhood? What are a couple questions that we could ask the patient while we're doing our admission assessment? Does this happen only during exercise at a certain time of the year? Do you have any known allergies, such as pet dander or pollen? When's the last time you did a pulmonary function test, PFTs? Peak flow monitoring, part of the asthma guideline, asthma national guideline, peak flow monitoring, and we'll talk about that towards the end of the lecture. Chest x-ray, how are we looking? And of course, our lovely ABGs, and those hurt. I've never had one before, but they pretty much have to stick you pretty good in order to get an artery. So back over to pulmonary function tests, PFTs, pretty much a group of tests that measure how well your lungs work. The tests determines how effective your lungs are able to bring oxygen to the rest of your body. How does that work? Well, what does it consist of? PFTs include a spirometry. This measures the amount of air you breathe in and out. Usually the patient sits in front of a machine and be fitted with a mouthpiece. Then you are to breathe normally, or whatever the machine says, and then it'll give you your PFT results. Oximetry, our lovely pulse oximetry. Allergy testing provided by your primary care. They should test for environmental and food allergies. Blood levels of eosinophils, sputum culture, and sensitivity. Collaborative care for asthma. What should a patient with asthma carry around them at all times? Or if you have a child with asthma, what should they have? They should have an action plan. Basically, it's nice little sheet that informs any emergency medical service attention or their teacher of what to do should they, show signs and symptoms of mild or moderate asthma attacks. So this asthma action plan is developed with your doctor. Detailed plan for taking medications and managing an asthma attack. And that's because asthma is an ongoing condition that needs regular monitoring and treatment. You want your patient to take control of your treatment and be pretty much in control of their life in general. Each action plan is tailored to the needs of a patient. Acute asthma episode. What are some nursing interventions that we could do? So usually if it's a controllable acute episode, we're going to give them their rescue inhalers, administer O2. Should they not respond to the inhalers or rescue inhalers, then they're going to have to move over and give corticosteroids because the initial response is not enough. How long do we keep, giving these medications to the patient? Well, until they find relief or they're at their usual baseline. In relief or the patient's breathing comfortably, wheezing has not necessarily disappeared, but at least diminished. So for our severe asthma attack, status asthmaticus, almost the same as treating the acute episode. However, there's probably going to be an increased frequency and dose of the bronchodilators, and also breathing treatments will be given. Should they fail, instead of oral corticosteroids, we're not going to start IVs. And of course, your O2. And once they reach the point of a silent chest, they're probably going to be intubated and put on a mechanical vent. All right, our favorite part, asthma drug therapy. So you have your long-term and your quick relief. Long-term, I'm talking about controllers and preventers, or your combination drugs. And then you have your quick relief or your rescue medications. Let's see, I'm gonna go back. Long-term asthma control medications. So these are taken regularly to control chronic symptoms and prevent asthma attacks. It is the most important type of treatment for most people with asthma. I'll give you a couple examples. Let's see. I'm gonna put it right next to long term. So you have your inhaled corticosteroids. You have your leukotriene modifiers. Leukotriene. LABAs. What does LABA stand for? Long-acting beta agonist, hence long-term asthma control. Or a combination of inhalers that contain both a corticosteroid and a LABA. Quick relief, rescue medications, taken as needed for rapid, short-term relief of symptoms. Short-acting. So we can say our lovely albuterol. Atrovent. And IV corticosteroids for serious asthma attacks. So what happens if it's an acute episode for allergy-induced asthma? These medications are taken regularly or as needed to reduce your body's sensitivity to a particular allergen. So they could do immunotherapy. So we're talking about shots or anti-allergy medications. So that would, not anti-allergy. Well, yeah, I guess anti-allergy medications. So what is there? Cetrizine, I think. I don't know if I even spelled it right. But that's what we had to use for my son. Bronchodilators. our quick relief medication. Previously, we said albuterol and level albuterol. So these medications open up the lungs by relaxing airway muscles. So, bronchodilators relax airway muscles. Often called rescue medications because they can ease worsening symptoms or even stop an asthma attack in progress. They should only be used as needed and not for daily use. Some people use a quick relief inhaler before exercise to help prevent shortness of breath and other asthma symptoms. If your patient finds out that the symptoms are minor and infrequent, or if they have exercise-induced asthma, they can probably manage it with just this medication alone. However, most people with persistent asthma also need an inhaled corticosteroid or long-term control medication. Or if the patient needs to use an inhaler more often than usual, then they should probably meet with their doctor so they can get their asthma under control. Yeah. I guess I went too far on my slides. So yes, bronchodilators, they can prevent bronchospasms in exercise-induced asthma or other stimuli. However, remember, we can't use it daily. Do not use daily, because now you're gonna create a rebound bronchospasm. And like I said, if they're using it way too frequently, they gotta go see their PCP. Revise their action plan and their medications to appropriately control it. So, avoiding contact with tongue to decrease side effects. Why? Why do we have to avoid the tongue with bronchodilators? Oh, long acting. So we have a long acting bronchodilator. I was still talking about or thinking about short acting. Long acting. All right, so now we're talking about our LABAs, our LABAs. Long acting beta agonists. So you got your formoterol and salmeterol. Examples of combination inhalers with LABAs, that would be, let's see. Let me write down here. Most common LABA would be your Ceravent. And then for our combos, you got Advair, Symbicort, and I'll do one more, Dulera. Anti-inflammatory drugs are the most effective and commonly used in long-term control medications for asthma. They reduce swelling and tightening in the airways. Let's see, the patient would probably have to use this medication for a couple months to receive maximum benefit. Let's see, a couple examples for inhaled corticosteroids. Flovent, Pulmicort. Now, the problem with inhaled corticosteroids in children specifically, they can delay their growth slightly. But then again, you have to outweigh the benefits and the risks when using these medications with children. So they're going to have to seek the benefit, right? If my child is going to be using inhaled corticosteroids, I would rather have him use it to maintain good asthma control and outweigh the risk of him or her having a slight growth delay. Side effects for inhaled corticosteroids, they don't really cause that much, but when they do, they can include a mouth and throat irritation and, of course, oral yeast infection. So we can say corticos equal yeast. So it's going to be very important that if they do inhale corticosteroids, that they're using a metered dose. It's going to be found on the top or side of the inhaler, a spacer. If they don't use a spacer, please educate your patient that they need 2 fingers away from their mouth, from lip to inhaler. And let's see, rinse their mouth with water after each use to reduce the amount of drug remaining in the mouth that could lead to oral yeast infections. Can emphasize enough that if you see in the general population or like in TV shows, they put the inhaler right to their mouth. Well, of course, that's not going to work, right? Once you administer the medication via MDI, that medication is going to end up where? Right in the back of their throat. Medication is not going anywhere to where it needs to be, right? So they need a spacer so they can coordinate and inhale at the same time when they push on the MDI. You'd be surprised how many people don't know what MDI is. Meter dosed inhaler. Couple things you have to remember with the corticosteroids: they do not block the immediate response. So this is not going to be one of your rescue medications. Mast cell stabilizing drugs. So they inhibit the release of the allergic mediators from mast cells and are used to prevent allergic reactions to common allergens. So this type of medication, you probably want to give it to the exercise-induced asthma. So you can see here, effective when given 10 to 20 minutes before exercise. It's a preventative treatment of bronchial asthma, allergic conjunctivitis. But these medications tend to be expensive and their dosing schedules are more frequent, so it's not a widely used medication. Continuing on with our preventers. So our first preventer medication were inhaled corticosteroids. Our second preventer is the leukotriene receptor antagonist. Most common one is Singular. These medications block the effects of leukotrienes, the immune system chemicals that cause asthma symptoms. And they can prevent symptoms for up to 24 hours. Very rare side effect in cases that singular or montelukast. Let's see here. Montelukast. Cause psychological reactions such as agitation, aggression, hallucinations, depression, and suicidal thinking. Once again, those are very rare cases. So, we talked about relievers, controllers, combinations, preventers. Sounds a lot for the patient to take in. Well, if I have this symptom or I feel this way, I need to take my corticosteroids, but then I have to do this combination because I'm going to go play basketball. Wait, no, that's inside. I'm going to play football in about 2 hours, and I have to remember that within 10 to 20 minutes, I need to take this medication. Or do I have enough rescue inhalers? One for my bag, one for my duffel, or maybe even like one in my car. But those are just the kinds of things that you think about when you're teaching your patient, or questions that they might ask you and their asthma. So like we talked about earlier, some people might have difficulty using the MDI spacer or having trouble keeping it 2 fingers length away from their lip to MDI. Some people don't have the coordination to inhale and press the MDI at the same time. So what is another alternative? Well, you have your dry powder inhaler, or your DPI. I don't know if you've seen it on the floor. Basically, it's a little egg-shaped. I'm going to say Spiriva for example. Let's draw Spiriva. So this is the little DPI. Looks like a little egg. You got your hinge here. And then they push a button. Okay, so they push the button. And then pop. Let's see, the cover's right here now. And it's right here. Now they have to drop in their little pill. It looks blue. I'll use this blue again. It's a little blue pill that goes inside right here. Then there's like a little mesh right there, and then it has like a little capture bowl right here. So patient puts the little blue pill in there, closes it, pushes the button. Again, it could either pop or it can now crush or poke a hole in it. They keep pushing and pushing and pushing. Now all of the contents in the inside are now fallen or have fallen into the capsule here. So what's left? What's left is the empty capsule, because now all the powder has fallen down right into the bowl cavity. They're now ready to inhale. So this comes out. There's a mouthpiece here that also latches off or hinges off to the side. And then they inhale the powder. So it requires less manual dexterity, and of course, this is a big one with the coordination. Basically, they pop a pill in, push the button that crushes the pill, take the pill out, and then all that's left is that they have to inhale the powder. Now, don't forget to take out the remains of the capsule because patient won't get the medication if the capsule is blocking the pathway of the powder. Inhalers, especially those patients who decide to put it on their lip and they don't use a spacer, please have them clean around the port or entry site. Their caps, some of them could be dirty, or even let's say your child plays t-ball. They are probably in that age where they just throw things around, so there's going to be dirt and dust in the cap. And what is the general rule? If you need to take a rescue inhaler and then you have to take a corticosteroid, you take corticosteroids first and then albuterol, or albuterol and then corticosteroids. So albuterol first and then the corticosteroids. Why? Because your steroids aren't going to go in if your airway is blocked. So you're going to open up your airways first and then take the inhaled corticosteroids. And then you're going to rinse your mouth so you don't get oral yeast infection. All right, so we're going to talk about the peak flow. Peak flow should be done per action plan. Peak flow meter is pretty much a portable and inexpensive handheld device used to measure how air flows from your lungs in one blast. They come in two ranges to measure the air pushed out of your lungs. A low range for small children and a standard range for older children, teenagers, and adults. Why? Because adults have larger airways than children, so they need a larger range. So why? Why should we measure their flow rate? Why? So it can help your healthcare provider make decisions about your treatment and adjust medications. It can also measure or alert you when your signs and symptoms are worsening. All right. So if you notice from the video, there is a measuring device on the right of the meter, and they were showing the colors green, yellow, and red. Those are your zones. You should do it periodically or determine the zones, the appropriate peak flow value in liters per minute. I need to put in your zone in your action plan to perform the necessary interventions. So generally you want to be in the green zone. You're doing good. Continue on your medications. Once you start getting into the yellow zone, doctor says, okay, something is triggering it. What could it be this time? What was it? Did I forget to take my medication before I went to go exercise? That put me in the yellow zone? Have I not taken my long-term prevention medications? Am I in compliance with my medications? And of course there's red. Danger, danger, danger. Gotta go to the ER. I wanted to show you an example of an action plan. This is taken from the Asthma and Allergy Foundation of America, so it is a reliable source. Like I mentioned before, you need to figure out your measurements that go into every zone. So like we said here, green, continue medications. As is. Peak flow. Oh, I probably have to adjust it. Am I compliant? I might have to take this medication more frequent now because I'm in the yellow. I'm experiencing mild wheeze, got a tight chest. And finally, your red zone. I cannot breathe. If you're speaking to me, you can breathe. If you have trouble speaking, we got issues. So at that point, when your peak flow measurement is below 50%, you gotta go to the urgent care or ER. Medication is not helping. I'm breathing way too hard and fast. I am nasal flaring. Gotta go. I want to go over another common medication that is given at the hospital. Prednisone and Medrol. These are oral corticosteroids that are used for serious asthma attacks. These medications may be taken to treat severe asthma attacks. They can have bothersome short-time side effects and even more serious side effects if they're taken for a long time. So a couple examples of side effects for long-term use. Cataracts, thinning of the bones. So we can probably tell our patients or recommend them to take supplements or add a certain food to their diet. A decreased resistance to infection. Why? Now that you're taking a steroid, what happens? You're more susceptible to getting an infection, high blood pressure, and like what we discussed earlier, a reduced growth delay in children. How about an acute example? The only one I can think of is if my patient is diabetic or pre-diabetic, then that's going to raise the blood sugar. As nurses, what can we do as far as patient teaching, lifestyle, and home remedies? Although many people with asthma rely on medications to prevent and relieve symptoms, there are a couple things that they can do on their own to maintain their health and lessen the possibility of asthma attacks. So, of course, we want them to avoid triggers. How can they do that? You can use their air conditioner. Air conditioning reduces the amount of airborne pollen. You can also lower indoor humidity and reduce the exposure to dust mites. If they don't want to use air conditioning, they can try and keep their windows closed during pollen season. You want to decontaminate decor. It's also recommended that if you do have carpets in your home, remove them as soon as you find out that a family member has asthma. By doing this, it minimizes the dust that can worsen nighttime symptoms. They could start encasing their pillows and mattresses with dust-proof covers. And if they do have washable curtains and blinds, take them down, and I'd probably say wash them monthly in hot water with vinegar. Optimal humidity is necessary. I think it costs about $15 to have a reader for your home. We need to control mold spores, prevent or control mold spores. Pet dander is a big one. Pet dander. I know we love our furry friends, but if we find out that our furry friends are causing or is a trigger, we're going to have to find them a new happy home. Clean regularly. Regularly. Clean your home at least once a week. If you're likely to stir up dust, they should probably wear a mask or have someone else do the cleaning. As part of my project for SDSU, we came up with a asthma home bucket. So we geared it towards the lower income of our community. The bucket contains ingredients and alternatives that can be used for cleaning the home without using fragrant chemicals or any other triggering exposures or irritants to the throat. So there was a precise measurement for vinegar to water dilution. Don't use Clorox or bleach. Look it up. Cover your nose and mouth if it's cold out. Asthma is worsened by cold or dry air. Wear a mask. And of course, we can always teach our patients to stay healthy. Self-care theory. Regular exercise. So having asthma doesn't mean you have to be less active. You just have to know when and how to prevent your asthma attacks and control your symptoms during activity. Regular exercise strengthens the heart and lungs anyways, which helps relieve asthma symptoms. Sure, regular exercise. Healthy weight. We always want to encourage our patients to have a healthy weight because being overweight can worsen asthma symptoms. And overweight people tend to have GERD, gastroesophageal reflux disease. They need to control that. It's possible that the acid reflux causes heartburn that may damage the lung airways and worsen asthma symptoms. So, in addition to their asthma medications, LABA/SABAs, rescues, or combos, they probably need a medication to control their GERD. Now we're looking into alternative medicine. For all my alternative medicine people out there, what can we do? Just want to point out that keep in mind that these treatments are not a replacement for medical treatment, especially if you have severe asthma. So always speak to your provider before taking any herbs or supplements because they may interact with any other medications that you take. So we have good old breathing exercises, right? Breathing exercises if you don't want to put anything into your body. And herbs, them good old herbs. Caffeine. There is a medication called theophylline. The main derivative is caffeine. Black seed. Choline. And what's another one? Pycnogenol. So always talk to your provider if you want to take alternative medicine. This pretty much concludes the video lecture on asthma. Main pointers I'd like to say. Medications, LABA/SABAs, rescues, preventers, combinations. Asthma action plan, it needs to be developed. Peak flow meter readings. And let's see. Patient education, right? Avoiding triggers and stay healthy. Imperial Valley is air quality is not that great. I also helped out in a project with STSU and a couple of my classmates. If you notice that in all the elementary schools, there are color flags that are posted. So along with the the American flag, there's a color flag based on the air quality that the Imperial Valley has. So if it's red, those students with asthma should probably stay home. There's yellow, green. I'm not sure if they updated the action intervention with putting it in the app communication for parents. I believe they started placing it on each of the schools' websites, but I'm not too sure. So yeah, there's a couple things that have been implemented in the Valley. Another thing is the Salton Sea has been brought up to the Board of California. I don't know if you guys are aware of this. The Salton Sea plays an important part in environmental and agriculture. So I would advise that start being proactive in possibly saving the Salton Sea. We do know that it's highly a huge contribution to the poor air quality, and The state of California's got to fix it. So look into that. Save the Salton Sea.